Good morning, everyone. Thanks for joining us. My name is Lee Hundley. I'm technical lead with the NTD Support Center, the Secretariat for Core NTD. I want to welcome you to our free Core NTD meeting, Fake News and Trust in NTD Health Programs. I just wanted to briefly mention a couple technical items before I turn it over to the speakers. If you could keep your video turned off and your microphone muted throughout the session until the Q&A and breakout room portion, that will just help with bandwidth and help with background noise. We will be having 3 presentations prior to the Q&A. So if you have any questions that come up during the presentations, feel free to put your questions into the chat box, and we will address those during the Q&A portion later. And lastly, if you have any issues with Zoom as we're moving along, feel free to send me a private message in the chat, and I can help you resolve your issues, hopefully. And then with that, I will turn it over to Dr. Justin Mono to begin the session.
Okay, thank you, Lee, for the introduction. And let me reiterate the hello to all and welcome to this Core NTD 2020 pre-meeting on fake news and trust in LTD health programs. So I'm Justin Nonokongep from the Ministry of Scientific Research and Innovation of Cameroon and co-chair of this session together with Dr. Poppy Lamberton from the University of Glasgow, UK. Hi, Poppy.
Hi, welcome everybody. Yeah, sorry, just unmuting. And yeah, so we've got 3 exciting presentations today. These have been pre-recorded, so there shouldn't be any problems, hopefully, with any connection issues. And what we're going to do is we're going to have each of the 3 presentations in order, and then we're going to have a Q&A session at the end. So please do type any questions you have as you go along in the chat box, and we will make sure that we come to as many of those as we can during that Q&A session. So first of all, we've got a talk from Cosmas, who's going to be talking about insights from Schistosomiasis MDA in Guinea, Conakry, where mistrust in authorities and inadequate social mobilization hampered control program efforts. And yeah, we've very much looking forward to hearing from you, Cosmas.
Hi, I'm Cosmas Ejong Ndelejo, Technical Advisor for Schistosomiasis and Soil-Transmitted Helminthiasis at CITERIS. I'm going to be presenting the impact of mistrust and inadequate social mobilization during mass drug administration with praziquantel in Guinea. CITERIS has been working in the NTD sector for several decades, with extensive experience in mass drug administration. We currently run a Schisto-SCH program covering 5 countries across Central and West Africa, namely DRC, Cameroon, Nigeria, Guinea, and Guinea-Bissau. Our work in Guinea started in the Nzere forest region, where we treat school-age children and adults with praziquantel against schistosomiasis in Lola, Yomo, and Nzere health districts because of the very high prevalence of schistosomiasis in these districts. In 2019, we secured funding from GiveWell to expand in Kindia, Conakry, and Bokito regions, covering 5 health districts. This presentation highlights the impact of miscommunication arising from side effects following mass drug administration in Kindia and Bokito regions, as you can see highlighted in the red text boxes. Activities began very well in Freya, Koya, and Jubreka health districts. Freya Health District was the first to launch the MJ campaign on Monday, March 18, 2019, after training of health workers, community volunteers, and teachers. The launching ceremony was presided by the local administrator called the Préfet, but also saw the participation of health and education officials. There you find the Préfet at the École Primaire de Gandhi in Freya Health District, demonstrating drug administration using a dose pole. The student in the picture is also measuring the height of a student to determine the number of tablets required and also marking the index finger to indicate that treatment was administered. In Guinea and other countries, we operate hybrid platforms where treatment is simultaneously delivered in school and communities to optimize program reach to both enrolled and non-enrolled school-age children. There you find also a CDD recording those that have been treated in a community register designed by the National NTD program. Planning and training had already taken place. Everything was moving on well with the campaign until drug administration started. Site servers and the National NTD program were alerted of consequential side effects by independent supervisors of a local NGO called Association pour la Promotion de la Santé en Guinée. This local NGO was hired to support independent monitoring and also social mobilization. Field teams from Koya district were first to report parental unhappiness due to side effects reported by their children. Additional reports from Dubreka and Freya district indicated other cases with side effects, causing protests in some schools and health centers in these districts. News of the side effects was spread across communities in 3 districts, the capital, and even to other localities around. The reported side effects were diarrhea, abdominal pain, dizziness, fever, and rumors of death were also in certain papers and radios. Out of 6,000 plus kids treated, 200 plus came down with side effects. It's one thing to have a crisis, it's another thing to manage a crisis. The Minister of Health in Guinea demonstrated good leadership in crisis management. A cabinet meeting was hosted on the same day, on March 18, 2019, and a decision was made to suspend distribution of drugs until further notice. A delegation from the Ministry of Health, headed by the National Director of Community Health and Director of Health Inspection, made several visits to the affected areas to rebuild trust in the communities affected. On the same day, MDA was suspended. A TV speech was delivered by the National Director of Major Epidemics and Pandemics to reassure the population that there were no deaths as suggested by the rumors. The crisis was de-escalated under 24 hours and calm was returned to the communities affected. The numerous conspiracy theories surrounding the COVID-19 pandemic with a lot of misinformation has made the management of fake news quite challenging. And I will be inviting us to a breakout session to discuss how to identify misinformed communities. Thank you very much.
Thank you very much, everybody. Thank you for a great talk from Cosmat. So just that was our first of the 3 talks for this fake news session. And so that talk was really focusing on, you know, when something arises, what happens to combat that, and rapidly informing the people to get back and to inform the community that this is indeed fake news. Our second speaker today is Justin Nono, and he's going to be talking a bit more kind of about, again, misinformation and mitigating it in the first place. So how to prevent misinformation from arising, and use an example where, in fact, unfortunately, it has arisen. So thank you. Over to you, Justin.
Good day, all. My talk of today is about the usefulness of community-led health education of peers to mitigate loss of trust in health specialists and services. An episode from Bokito in rural Cameroon. Well, the episode I'm about to narrate occurred in a rural zone of the central region of Cameroon, particularly in the northwest of this region, 112 kilometers north of the capital city of Yaoundé, in villages of the locality of Bokito. The locality of Bokito is indicated here in red and is part of the health district of Bafia, which is moderately endemic for Schistosomiasis. As part of a clinical study focusing on the determinant of schistosomiasis transmission and morbidity, we plan to survey 5 primary schools of the locality, that is in the village of Ejolomo, Keja, Yoro, and Bogando. All nationalists and institutional clearances were obtained, with some chosen captures here with the Ministry of Public Health, Director of Operational Research, and the Coordinator of Helmet National Control Program of Cameroon. And the information sessions were conducted by my team and I for parents, school children, and school teachers on the goals and proceedings of our studies shown here. So at the time, we thought these information sessions went very well, giving the audience engagement, and also considering that the site has been receiving praziquantel treatment from the National Control Program for more than a decade, making it very likely then for the people there then to understand the need here of our study on the specifics then of schistosomiasis transmission as well as burden. Around then, October 2019, this is just a month after the information sessions, we proceeded with enrollment, the parents and children consent as well as asset basis. And these clinical studies then on the determinant of schistosomiasis transmission and burden necessitated stool collection, abdominal ultrasonography, blood collection from the children who had provided asset and guardian consent for the study in general. This went up well until a month later, by early November 2018, when parent concerns with biopsies taken were reported to us. We then had a group of angry parents that came to the school to voice their reservation, particularly here on the purpose of the biopsies. The root of such concerns were apparently fueled by the spread of superstitious belief of use of children's stool or blood for magical rituals. You do have to note here that the sites we were working on had then multiple rounds of MDA, but mapping of any kind of sampling then had not been done in this village specifically. So retrospectively, we could understand somehow, now that we know a bit better, that a certain caution should have been taken in questioning the best strategy to efficiently present to them the necessity and benefits of collecting stool and blood samples, for example, to better plan future control strategies in the region. School directors were threatened and traditional chiefs then were notified by the parents who, as they said, did not know what we are doing with their children's tools, as they reportedly in fear for their children's safety should we engage in those magical practices with these collected samples. Tragically, then, when confronted, then this parent did not want to listen to any direct explanation from members of my team. To be honest, we were not sure here on how this misinformation and sudden lack of trust came about, but had to methodically address it as the study was immediately interrupted to avoid further escalation of the issue. Analytically, this meant that our traditional information strategy, that is ranging from securing the clearances, meeting with authorities, and subsequent information sessions of the masses by the research team entirely as used so far by my team on other sites, was not sufficiently robust to prevent misinformation problems in the study start of Bokito. This traditional scheme, then, as depicted here, is rolled out to have then the research team inform community leader and the masses. The second point of the mitigation strategy, after acknowledging failure of our traditional model of communication, was to understand how best we could proceed then to get information across them to the parent on the usefulness of stool and blood biopsies for our clinical study on the schistosomiasis and the importance of the analysis then of these biopsies in defining or informing the design of tailored and novel control strategy. And in so doing, then, to gain back the trust of the parents, we consulted with the school directors, the highest administrative and traditional authorities in the locality, and with well-respected traditional elites of these communities. These meetings were set with my team to gather feedback on what could have gone wrong and how the message be better vehiculated to the community to get them to understand fully the goals behind the present study and come back then to the study. The points of interrogation were on what could fuel then such fear in the community. How could my team then do to prevent this, and how best then to communicate with parents from the area in the future? The key and shared suggestion from the meetings was the following, as translated then from reports in French. Empower community leaders as much as possible with the knowledge so as for them then to proceed as frontliners in the information sessions of parents and children on the study proceedings, the benefit and risk of the action. In fact, it was clear from the meeting that locals were unanimously categorized as refractory to naval actions driven by non-locals. So the traditional scheme of proceedings to information we had was no longer valid here and had to be readjusted as per the findings from the investigation meetings. Therefore, another exercise of reinformation of the parent via the school teachings and traditional authorities started by the end of November 2018 during this session led by local leaders this time and not the research team primarily. We noted a progressive change of mind and loss of apprehension of the parents as some of the key points of the study basis and objectives were provided, at times in a local dialect. This rather fortunately then brought back the community to support the continuity of the study, as flyers were then sent to inform of the resumption of the study following this game-changing meeting with community leaders led information of the masses. The study resumed by December 2018 and was successfully completed in January 2019. In conclusion, then, our presently reported misinformation and loss of trust episode in the context of clinical schistosomiasis in the rural site of Bokito in Cameroon did benefit from community-led reinformation of peers in enabling the mitigation of the incident. This is not uncommon in clinical studies in rural areas, and increasingly so in urban areas, with the considerable escalation now of fake news of all sorts in the midst then of the present COVID pandemic. As such, we could greatly benefit in planning and to discuss in our upcoming breakout session on loss of trust and mitigation about how to secure community trust in the communities was to have this health information across, how to prevent loss of trust into health services in communities, how to oppose misinformation or lack of information, and how to sustainably then empower the community with health information and acceptance of health service practices. These points and other you might want to add then could be discussed during the upcoming breakout session on mitigation of misinformation in the community, where you will be provided with the link displayed here to contribute your feedbacks on these raised points of discussions. Well, on this, I would like then to thank all the funders that are involved in the support of the health research in my laboratory, and thank you all then for your attention.
Thank you very much, Justin. So now that's sort of two talks we've had. We've had one from Cosmas Njelong speaking about the importance of the speed of countering misinformation, and then Justin Nono talking about how the importance of community-led sort of information to mitigate misinformation possibly in the future. And now we'll be hearing from Dr. Kwa Kamoji, and she's going to be talking today about opposing misinformation and what we can learn from pandemic crises for long-term health system gains. And this actually also will lead quite strongly into the actual core NTD session in November, where we'll be really focusing on fake news and COVID and possibly interactions with NTDs and COVID there. So over to you, Kwa.
Greetings to everyone. Thank you for your attention. I will be discussing themes from program experiences managing communication during the Ebola epidemic in Sierra Leone and Guinea, and the ongoing work with COVID-19 rumor management conducted by the Johns Hopkins University Center for Communication Programs. I will start with program challenges from misinformation in a public health emergency, and then discuss what we know about how to counter misinformation in a pandemic. Challenges stemming from misinformation about public health interventions are much more complex than can be expressed in a rapid session. However, there are some general findings distilled from our work that are relevant to other community-based health programs. First, misinformation undermines trust. The panic and fear that characterize infectious disease outbreaks can reveal lurking fissures in public trust when existing communication issues are amplified. Lack of trust creates barriers and negatively affects the relationship between program implementers and beneficiaries, including the uptake of health services. During pandemics, the health system and health workers also experience similar anxieties as the general population that also create barriers with the communities they serve. Misinformation hampers ability to make informed choices about preventive behaviors, in turn influencing poor cooperation and non-compliance with public health directives among community members. Misinformation also may increase ineffective and harmful behaviors, including an increase in risk-taking. And when it targets specific groups or activities, can lead to stigma and violence. There also is increased likelihood that communities will globalize issues related to the specific crisis and extend their negative perceptions and misgivings to other government work and to future pandemics. Communication before and during public health emergencies, therefore, has a key role in establishing strong relationships and trust between caregivers, programs, and those receiving services. So what have we learned about managing misinformation and rumors during pandemics to build resilient communities with some immunity to misinformation? First, it is important to act quickly and put out the fire fast. Short turnaround time requires that programs should be prepared and have a plan in place to manage misinformation. A quick response minimizes the scale of the spread of misinformation and prevents the spread of variations of misinformation that tend to evolve with time. It also is easier to identify the source of information earlier rather than later, and rapid response also helps to mitigate potential severe consequences. Formative work may be necessary for discovering misinformation. Depending on the misinformation and scale of the problem, this could be a rapid or a more formal research activity. Trust is an important construct that affects almost every aspect of health-related interactions and needs to be understood in the local context. How trust is defined traditionally varies and can be a difficult construct to understand. Trust has been defined as ability to meet health needs, honesty, communication, competence, fairness, confidentiality, provider agency, quality of relationships, and meeting expectations. In Burkina Faso, in the Mori language, trust is translated as I give myself to you. In Sierra Leone, it is defined as I believe in you. In Guinea, qualitative research we did show that salient trust constructs included competence, hospitality at the facility, compassion of providers, honesty of health workers, and confidence. So this is a construct that you have to explore in your local context and understand how misinformation affects trust. Formative work is also necessary to understand the context of the misinformation, specifically how it spreads, who it targets, and how it impacts the community. It is also important to know how communities prefer to receive health information, who is considered a credible source of information for a specific public health issue. Preferred and credible sources are not necessarily the same, but the ideal is when they are. Communities themselves can be effective weapons against misinformation. It is the norm to engage communities in program delivery, but it is not the norm to routinely include communities in strategies to prevent misinformation about program interventions. Listening to and in communities is an important first step. Building on existing and trusted relationships and using these networks to listen is a quick approach for hearing how a community feels about a particular issue. Use your frontline health workers, your household visitors, your volunteers. This allows early recognition of misperception about a program. A program's response to misinformation is more than simply putting out correct information. The response often extends beyond the geographic boundaries of the program. Different groups within communities respond differently to the same misinformation, so one must accurately identify the key audience that needs to receive correct information, or the different needs of subgroups within the population. With training and resources, community members make credible, influential spokespeople to counter misinformation and to rally the larger community towards the truth. Engaging the community in the solution facilitates the development of an informed, trusting, and cooperative community who is ready to help you advance your program goals. Rumor tracking works and should be a part of programming. Rumor tracking is a system to identify, track, and address misinformation, as well as monitor how well the tracking system and the program are working to counter misinformation. Rumor tracking does not have to be a sophisticated system. It can be simple or digitalized, or just simply captured in an Excel operating platform. However, one does need a specialized team of influencers, content experts, program staff, and health authorities to help with rumor tracking. It involves rumor tracking logs, classifying rumors by source, by content, who it targets, how it is channeled and spread, and the location where it is spreading. It also includes classifying the potential threat from the misinformation. Does it cause harm? Does it increase risk? Does it hinder access to service? Does it cause conflict? Does it increase stigma? Things like that. So it includes a subjective interpretation of how that rumor might impact that community. And that's best done by engaging community members. So the next few slides show how you can capture rumors in a database. On the left is an example of a rumor tracking log. On the top, you have demographics. Then you have some information about how the rumor was, or the message or misinformation was received. And on the bottom, you have the actual content of the misinformation, the specific misinformation. To the right, you have an example of data entry for classifying misinformation by themes, things like access to resources, beliefs about susceptibility, denials, fear-mongering, conspiracy theories. You just have to create a thematic response option that captures the actual effect of the misinformation in your community. This slide shows how you can digitalize your misinformation. This is from a DHIS2 dashboard from one of our projects in South Africa. And on the left, we just have real-time data on the volume of rumors that are being submitted to the platform. And on the right, you have disaggregates of rumor submissions by province. So you can look at where in your program area there's more information relative to other areas where you might be having a problem with community buy-in. This slide is a visualization of misinformation by thematic area or by topic. So it is apparent from this that misinformation about treatment, about government response, about prevention, conspiracy, and access to resources are more prevalent types of misinformation. Gives you some idea of the kind of information that the community is either lacking or not understanding. And you can track on a smaller scale. It doesn't have to be as wide a scale or as large as this one. This shows how misinformation can be disaggregated. On the left, you have misinformation and rumors disaggregated by the submitting source. And you can see that by far, community informants are a good way to capture rumors in your community. On the right, you can drill down by type of rumor and see how a specific type of misinformation or rumor is spread in your community area. We have conspiracy theories taken out of all the kinds of rumors and shown how they are prevalent in the different program areas. So all in all, a multi-pronged approach is the best way to tackle misinformation and rumors in a community. Multiple actors, multiple channels, and one consistent message. It is key that all groups say the same thing about the same issue. Identify relevant program stakeholders to assist with managing misinformation. When misinformation plagues a program, it is more effective to have all stakeholders and partners come together to address the program. It is very rarely in the domain of the program officers or those who are actually implementing the program. All stakeholders have to be brought to bear. Rumors travel in and out of project areas, so to speak. So one may have to identify and engage partners from outside of the community. For example, local government, sometimes you have to go a level higher than the community. District health is always a great endorser. Radio stations and mass media can help. Leaders of influence groups like religion, youth, women, content experts. Depending on your misinformation, you may need content experts to provide facts, credible facts, or experts from a source that you know would be accepted by the community. And of course, your program staff. An open and transparent approach is essential For instance, if misinformation is due to a particular approach, it usually works better to admit the mistake than to be defensive. Rumors propagate through multiple channels, and one must use multiple channels to share corrected information. Dialogue is always an important approach because there is a lot of emotion linked to misinformation. There's fear, there's anxiety, there's anger, there's mistrust, all of which needs to be addressed. So it's not simply disseminating corrected information, but also allowing community members to share how they feel about what they heard or what they perceive. In addition, one can develop and share corrected narratives, and these are best done with the community. Community voices are great amplifiers. They can be trained to counter misinformation and relay correct information within the community. And of course, monitoring the response to new narratives is needed, and that can be done through your digital dashboard or through informal discussions with community members. So from the beginning, identifying rumors to the end, measuring the response of your interventions to counter misinformation must involve your community. This last slide has some links to a few resources that you can use to help develop either a misinformation management campaign or also to develop a platform for managing misinformation for your program. Most of the principles discussed in this session came from these resources. For Group 3, we will be discussing how to ensure success of mitigation strategies against misinformation in the community, focusing on 3 questions, focusing on research and programs related to these 3 questions: how we can verify effective communication on NTDs and related health services, ways to ensure sustainable transfer and acceptance of health information, and how programs can ensure the resilience of an informed community in the face of misinformation. I look forward to a productive discussion with some of you. Thank you.
Brilliant. Thank you very much, Cor. So thank you for the 3 excellent presentations that have really highlighted the complexity of this issue and the importance of rapid response, community engagement, and really not making sure we don't have any complacency. So even though control programs might have been ongoing for a long time, if you're bringing in a new sort of, whether it's a test or something, really explaining that to those populations, and so they will understand exactly what's happening. So if we could just, so have we got any questions? We haven't got any questions in the chat. If people would like to ask any questions for any of our 3 speakers, we've now got 10 minutes or so to really quiz them on things, but also we have got the 3 breakout sessions that we'll be having in a minute, where we can also dig deeper into some of these topics. So it's a very quiet audience today. Have we got any questions? And please also just wave your hand or unmute yourself if you'd like to ask a question. I can kick off with one for well, actually all 3 of the speakers really. So I was just wondering if there were any examples of NTD programs which have got a sort of preparedness plan for misinformation, should anything arise, and if any of you know of any of these, and if that's sort of disease specific or whether it's country specific, because obviously there might be different plans needed for different interventions. Maybe I'll ask Cor that first.
Oh.
Or
Jasmine. Yeah, this is Cor. At CCP, the Center for Communication Programs, we haven't in the past managed or created a misinformation strategy for our NTD programs, but in recent months, this has become more important, not only to our funders, but also to our program staff. And it was only yesterday that I got an inquiry from one of our programs saying that they had been asked to include a misinformation strategy in our regular program. and they needed some guidance. So I think it is becoming more of a priority among funders and among program implementers too. But for us in the past, we hadn't until recently noticed that it was something that had to be a feature of our regular programming. Yeah.
Okay, thanks, Cor. And Cosmos and Justin, do you have anything to add to that question?
Well, the only thing I could say as a follow-up then to that will be that we might as well also need some guidelines when first proceeding in a naive community. You know, now with the upcoming of the subject street level mapping, a lot of the previously untapped villages will be included, in as much as some of them might have received an MDA, like was the case in the presentation I just gave. It could well be that we might have then, especially post-COVID time, have to face then such spreading of misinformation in the community, or fear of the unknown. And I guess then guidelines then to be able then to address. So the first basis, some of these communities that are naive to some of the proceedings we have in a lot of NTD health programs will also be needed and should definitely be discussed in, after our breakout sessions.
Thanks, Justin. So that could well, that's sort of some really key operational research questions that we need to ask of what is the best guidelines, and then ultimately produce those guidelines, I assume. And thanks, Cosmos.
Thanks, Poppy. Yeah, I just wanted to add that application of those central to communication is very important. It's important to educate journalists and get them well informed, because they have a very crucial role when it comes to reposting misinformation to a wider audience. Thank you.
Okay. Thanks, Cosmos. So great, we've got a couple of questions in the chat. So firstly, one from Rita. Hello, Rita, who actually co-supervised her PhD, so it's great to have you here. Rita was asking, are there some issues that are particularly more difficult to deal with in terms of misinformation, or more likely to raise doubts from communities? So vaccines versus research studies versus maybe treatment or something going on. So, so there are any specific types of misinformation that are more likely to raise problems in the communities?
I could have a first say on that. Hi, Rita. The more invasive the procedure, so the more likely that you will have then misinformations, or let's say reflection that surrounding then the issue. Usually superficial then procedures, whatever the NTD program is, will be more likely be smoothly conducted within those communities without major then hiccups or problems rising around the practices that have been there. So in general, I think then, like it was the case in the talk that, the second talk that I just gave, the biopsies were the problem, or in the talk of Cosmos where you had then the side effect coming as the problem, but the administration per se just of the drug or the surveys or the usual proceeding, let's say in Schistosoma, the National Control Program actions are not as frowned upon as are than those that do engage in some biopsies.
Thanks, Justin. And Cosmos, do you have anything else where you might think, where you've experienced sort of specific areas with? I mean, I think obviously Justin mentioned the treatment that you presented on. He's muted if he's answering. Cor, do you have anything to add? And otherwise, yes. I can also, yes, go for it, Cor.
Yes, I have a few things to add. I agree with Justin completely that the more invasive the intervention or the activity that you are conducting in a community, the more likelihood that, there are some anxieties and fears that kind of feed off misinformation. But the other thing that we've noticed at CCP, because we deal a lot with behavior change, is whenever you are promoting normative change and a change that is entrenched really strongly in custom and something that has been going on for generations, there's always going to be misinformation linked to that. And we tend not to pay that much attention to it. We treat it as knowledge deficit. Let's give them the correct information and hopefully that will take care of the problem. It rarely does. When you have topics that have to do with reproduction and sexuality, or going against being the positive deviant in your community, there's going to be some resistance, and that usually has some misinformation linked to it. When we were doing our Ebola work in Liberia, Guinea, and Sierra Leone, one of the biggest barriers we came across related to communicating facts was, our ancestors have done this for generations and never died. Why are you now telling us that, we're going to die? It's all a myth, it's not true, that kind of thing. So normative change activities, not just the invasive, part of activities, but those that deal with normative change and creating some new norms in your community also may face misinformation barriers and things like that have to be addressed. And usually with those kinds of instances, you have to go slow versus with some a clinical trial or some kind of invasive activity, you may have to work a little faster in your approach to counter that information.
Yeah, thanks, Cora. That's and also particularly with the working fast, obviously in today's age, news and particularly fake news travels faster than it ever has done before with social media and everything. And I think also with the pandemic, as in the next session in the main core NTD conference, that will also be touched on about the importance within a pandemic where everything is changing in the background fast. And so any fake news can obviously also, new fake news can arise quite quickly as well. I just have a quick question from Anouk for Cosmos here. And so when you were talking about implementing a hybrid implementation program involving school enrolled children and non-enrolled children, do you know if there was a difference in the spread of misinformation or concern about side effects between these groups of children and their families?
Thanks, Anouk. Unfortunately, we're unable to capture this difference. We had intended to do a post side effect or adverse event response to find out how the communities were different in their response or in their reaction to the incident. But again, Guinea has been plagued with a lot of unrest and protests. So given that this activity was time sensitive, we're unable to go to the field to pick up this information. Yeah.
Okay, thanks, Cosmos. Yeah, it's an interesting point though, because obviously information through schools can be disseminated slightly more easily, but be that the real information or obviously possibly leading to fake information as well. We have another question for Cor. Mentioned that it's important to consider what communities consider as important health information or as authority figure. And can you expand on that, please? And how does this translate into colonial perception of power imbalance at the community level? So yeah, this is a really key point, and I think we'll touch on it later as well, but Cor, do you just want to answer that now?
Yes, and this goes back to your formative work. Part of your formative work is understanding what is important about the intervention you're planning to implement. For instance, let's take Justin's example. You're going into a community to deliver some intervention that involves, administering meds or something that's a little bit more invasive. In the scheme of things in that community, that's not a priority for them. We come across a lot of communities that are very poor, don't know how they can make their next meal. That's the priority. It's not going to the health clinic for some preventive intervention when their child is not sick. And it's similar to the US, where the poor, they kind of exist with in an emergency mode. We don't go for routine checkups. We don't go for just a physical. We are only in the emergency room when we are sick. It's the same in some of these traditional societies that are very resource constrained. They're not interested in having, vaccinations and, things like that. They're only interested in how am I going to survive today and start again tomorrow. So before you go in there with your intervention, you have to find out what do they know already about what you want to implement, and how do they feel about it. You have to change their priorities and make them understand that that's also important in the larger scheme of things. But more importantly, they have to understand what the potential consequences are. And I'm not just talking about consequences in terms of future, consequences of that activity. It goes back to your consent form. Sometimes, did you really give them all the information that they need to know that, yes, you can have side effects. They are fleeting, you can easily counter the side effects, but most of the time we just go in there, this is good for you. We tout the positive benefits and give less attention to some of the things that we think they don't want to hear. People deserve to hear the negative part of it, but they need to know, more importantly, how to counter that negative part. So in instance, I'm going to have diarrhea, make sure you drink fluids, make sure you don't take this on an empty stomach, like Cosmos's example. Those are the things that are important to make sure that your intervention doesn't get riddled with rumors and things that prevent you from achieving your goals.
Brilliant, thank you very much. Right, so in the interest of time, we'll move on to the next. So if we've got the slide deck, we've got 3 breakout sessions. It's slide 4 on the slide deck, if we've got that, if we can bring that up. Brilliant. Oh, that's perfect. So we're now going to be disappearing off into 3 different rooms. We're actually quite a small group today, but that does mean that it might be a really nice conversation between everyone. And, this is really trying to find the operational research questions for how to best to identify a misinformed community, and what do we not know, and what sort of examples we've got of things that have worked, things that haven't worked. And again, mitigating misinformation in the community, so how to prevent that from arising. And then in the 3rd group, we've got ensuring the success of mitigation strategies against misinformation in the community. So that's sort of more about the continuity of it and making sure, how do we monitor that this is being successful? And there is 3 different breakout sessions. We've got one quick, a question from Anouk, which maybe we can bring up after the breakout. She was asking, how can we embed rumor management into behavior change interventions? Yeah, she said she'll bring it up in the breakout group. But just what we'll do now is everybody is going to be automatically assigned to their breakout rooms, and then after 40 minutes we'll come back for a final sort of presentation to the rest of what we've discussed within each breakout group, and then talking about some final conversations and questions we might have there. So goodbye to some of you, and I will be in the same breakout room as some of the others, and I'll see you all in 40 minutes. Welcome back, everybody. So the breakout sessions weren't recorded, but this main meeting is being recorded. So thank you very much, everybody, for staying. As I said, we've got a small group, but everybody's stayed, which is nice. So I hope you all had some really good discussions. So first of all, Cosmos, we have got, Cosmos, do you want to just summarize your findings from the first breakout session and what your main topics were?
Thanks, Poppy. Yeah, we looked at several aspects of how to assess the level of information available in the community. We felt that it's important to really have a well-structured process when it comes to information dissemination, and also collecting feedback from the community. realize that we don't have um, standard procedures per se. So working with community workers directly could be getting feedback from community workers could be one of the ways that you can uh, best identify how well informed a community is, maybe during training sessions, during MDA, or when you're doing supervision and monitoring visits, during rapid assessment. That's also opportunity to identify how communities are informed. Um, we looked at opportunities like mapping surveys where you collect data, not only for parasitological indicators, but also behavior change indicators. Most Schisto programs have well-structured questionnaires to be able to assess knowledge and practice, as well as environmental sanitation when it comes to Schisto. So that was identified as a good opportunity to gather required information that will be used as baseline and help programs tailor their behavior change messages to be able to address some of those gaps identified. We also looked at the need for um, to understand the specific context. You know, Guinea, for example, which we highlighted, has been through a lot of, I would say, riots and manifest street demonstrations because the president was pushing for an extension of his mandate, which was outside the constitution, and there was a constitution amendment, and now he's going in for the third term, and it's been very challenging. So most of our programs really channel investment and resources through the national system. But if you find yourself in a context where there is little or lack of trust between the administration and the population, how do you do? We felt like really working with the local authorities, the local community leaders is an excellent way of mitigating that because these are people who are trusted, they live with their community. So working with them directly, giving them the right knowledge and skills and you know, when it comes to community interventions, it will help better with program compliance as well as sustainability. So those were some of the key things we discussed in our group. And the other thing was how to reliably identify misinformation or lack of information related to entities and health services. So we felt that there is a lot of assumption that people actually absorb the messages that we pass on, which at times is not very true. Um, we assume that, oh yes, we've done health education, oh yes, we have done sensitization and mobilization, but how do we assess the level of absorption of this information? So again, having a monitoring process in place during program implementation is very crucial for that. And how to tailor our messaging, tracking behavior change, interventions to different communities and populations. I was sharing the experience of Uganda, where they have made considerable advances with onco-elimination. The Carter Center adopted treatment by clans, where you have CDDs selected from their clans or tribes. So it showed that there was that level of trust and confidence when people from the same tribe distribute drugs to those from their tribe. So acceptance was high and the compliance also was quite high. So, but now it's easier in rural communities, but how do you tailor that when it comes to highly heterogeneous populations like rural communities? And lastly, we looked at training of community volunteers to sensitize and also help manage rumors. So these are our frontline actors. They are the foot soldiers. They are the ones that make things to happen on the ground. For us to be effective in our work, we need to give them the right skills, the right knowledge that is required, not only to pass on because they do sensitization a lot. That's part of their task. but we need to also train them on how to manage rumors, how to, properly inform the communities when rumors come up or when misinformation is being disseminated across. Thank you. Those were our main discussion points. If I missed out something, please Anouk and Katie just help me complement.
Brilliant. Thank you. Thank you very much, Cosmos. And okay, so over to you, Justin, and then we can move on to the second breakout group. And you were brilliant. Up it comes. Excellent.
That's great then, thanks. Well, in our breakout session, we raised a first fundamentally important problem. That was, I guess, the one of funding when it comes then to considering then this issue, particularly then for researcher, where you have funding bodies that focus then more on the rocket part of the science and eventually not too much on this whole preparation then of the setup into which then the study is meant then to be conducted. That means that particular community. So we address then those points that raised here as potential operational research question or knowledge gap that were identified, and we had some actions that came up as being the one that could help them to address this problem, particularly when we look at how to secure the community trust in communicating the health information. Primarily then here we were the view that the message should be clear and it should engage people in a locally appropriate way. That joins back also the part where of the Cosmos report that we need then to have a grasp of the social, economical, political, religious, as well as the cultural setting and background of the population before applying then generic guidelines. That's pretty much important. And it should be made in such a manner as to be acceptable and to the community where we want them to display the action. Let it be a control program or a clinical research program. We also need them to be able then to identify them within this community. And that goes then with all those considerations I just mentioned earlier. We need to identify the trusted source of information to be able then here then to secure the community trust. And that was very well exemplified in the talks, the second talk that was given. So mine on this episode then from Bokito. So the trusted source in this particular case was definitely not, in this case, the research team being seen there as non-locals to do or perform then something that was never done. So the population in that particular instance will rather prefer then to stick with the usual lie than the uncommon truth. And to be able then to break that, what you need here is to make sure that you have then the right member of the community then being able then to vehiculate your message. The second point in terms of operational research then question that could be taken here is how one will go about then specifically linked to NTD programs and health program in general, preventing the loss of trust of health service then in the community. And in so doing, we saw that this very much went with opposing also the misinformation, the lack of information. And here suggestions were mostly made then regarding the engaging the population then through the locally trusted system. And again, that's the one. So the locally trusted system are the one that are key then here in this particular process. Or do
we seem to, Justin seems to have frozen. Are you there, Justin? If not, we can always come back to you and okay, well, is there anyone else in that breakout session who had anything to add to what Justin was saying at this stage? maybe Lisette, are you there?
Yeah, I'm there, but now the points we discussed actually was, we were quite a small group, and the points discussed were already mentioned. Of course, because of my research background, I focused a lot on that. Yeah, no, sorry, little to add.
No, it's fine. Okay, in which case, what we will do, we will move on to breakout session 3. And, oh, Justin's back. You're muted, Justin.
So for how long was I off? Sorry, I was talking, not even noticing that.
No, you weren't. So, I don't know, maybe 30 seconds, it's fine. So I just said, Justin, can we hear you? And then Lisette said that you'd summarized everything so far quite well. So just if, where do we go?
The final point, if I may make it.
Yeah, absolutely.
Was regarding as well then the prompt action. So that was expanded 2 different talks, mine and that of customers, clearly stating that when you do want to open the 3 talks, when you do want them to oppose that misinformation, to mitigate it is important then to act swiftly, rapidly, be consistent, and make sure that you use the trusted local sources. So understand the social, cultural, economical, and religious then setting into which then the study is being conducted. So overall, then that was what came about as potential actions that could be taken then to populate this operational research question that were laid out then in this breakout session. Over to you then.
Brilliant. Thank you very much, Justin, and thanks, Lisette, for jumping in. Okay, well, we'll move on to the 3rd breakout session now for Core, which was Core was leading. And do you want to just quickly summarize what we discussed? We wrote so much, it's off the bottom of the page.
Yes, I know. We had a small group, but they were very productive and had a lot to say, a lot of insightful comments, but we didn't have much time to discuss as we had wanted. So for the first question, verifying effective communication on NTDs, the comments kind of fall within 3 main areas. One, the technical aspect of your communication so that it's effective. You want to make sure that the structure of the information is clear and simple so that your intended audience is able to understand it. There was the suggestion to use communication specialists to help with information strategies. The benefiting from pre-testing. Pre-testing needs to ensure that messages are interpreted correctly and that the community will get its intended message. We also felt that relationships were important for verifying information and that the ministries of health need to be encouraged to have a closer relationship with communities so that they could be used as trusted sources of information, whereas usually during pandemics, you find that unfortunately, many times government is seen as perpetuating some kind of hoax or something like that in some of these past pandemics we've had. The use of health workers, that health workers could build relationships with their clients and not in addition to focusing on services delivery, there should be opportunities to help health workers develop this relationship with clients where they can, includes checking the information that they know about the services or the program that is concerned. There was also some information about research, about finding out which communication channels, materials, and tools were successful versus not successful or were missing, and that, you know, during the process of a program, these should be checked not just at the beginning or at the end of it. You could also use coverage surveys and feedback mechanisms to elicit information on how well your correct information is penetrating your community or resonating with specific audiences that they target. For the second question, which had to do with sustainable transfer and acceptance, the group felt that it was important to design for the community and not always make the actual research activity the most prominent part of a program if it's research, but that it should be promoted also as something that benefits the community and has value for community members. And it has to be designed, of course, with the community rather than simply for the community. There was also a discussion about having respected community members be part of the promotion of your activity, but understanding that different groups within the program area may have different spokespeople that they prefer. Like youth may prefer someone different from older individuals, and men may review a different source of information compared to women, things like that. It depends on what the program is and what the information is that we're trying to relay. And then, of course, harmonizing communication so that the community is of one mind. They hear the same message from all different partners and different sectors. And so there's no confusion, you know, and it's more difficult for misinformation to break through that wall of solid fact that everyone is sharing. And there was also a feeling that government also needed to be trained. It's not just community members being trained about misinformation, but also government workers, especially when it has to do with a health related issue. They are an important source, and if they are closer to the community, like we saw in question 1 and then trained in question 2, they can go a long way to help counter misinformation quickly. And then for our third question, ensuring the resilience of an informed community, of course, listening to the community was one of the first thoughts that came, building on existing networks. Of course, it mirrors a lot of what we heard from Nono and Cosmas, that we have to understand the channels that spread misinformation versus the ones that spread fact. And that also gives you some idea of who the audiences are, because they use different channels. Some research is needed to explore susceptibility to misinformation within the community, to identify risks, risk groups, and also to figure out how one can identify communities at risk of misinformation or communities that have misinformation when you have a large program area. But the key thing for a resilient community, we thought, was to be proactive and have a plan in place for managing misinformation, so that if the rumors of misinformation begins to trickle, you are prepared and everyone knows what role they have to play to counter it earlier rather than later. That was group 3. Thank you.
Brilliant. Thank you very much for another comprehensive summary of, yeah, it's such a fascinating topic, and sort of listening to all 3 of the talks and also all 3 of the breakout sessions, obviously it really highlights the complexity of it, but also something that everybody's touched on is the community involvement and also key stakeholders. So moving up from whether it's the program managers or the government as well. And and the need to, I mean, ultimately what is needed is sort of more generic guidelines that can be used across diverse situations. So it's really sort of trying to find out what are the key questions we know to ask now, so that we can actually put a plan and help different countries and help different control programs put in place particular, I guess, procedures or sort of mitigation strategies, but also prevention, also counter strategies should misinformation arise. And particularly when you're talking about how to identify a misinformed community, obviously that's not a one-off. You're not going to map a country and say these communities are misinformed or not. This is going to be, one community suddenly becomes misinformed and then that spreads. So it really is an ongoing feedback loop, if you think. So there's been several things coming across all of these, and I just want to open it up for more general discussion if people want to tease out sort of specific things that they've noticed, or if there's something that hasn't been added yet. So please just, if anybody wants to speak, do either drop something in the chat or just turn up, we're a small group, so turn your mic on and have your say. Anybody? I mean, we're nearing the end. Yes, Justin.
So let me take what was the question from Anouk, actually, that could give also a little bit of discussion point. That was, how can we embed rumor management into behavior change interventions? I think that's a great question, actually. And I mean, the suggestion, just to kick that off, is perhaps having indication on where within a community to find then trustworthy sources of information. So this is a pattern that needs then to get established. So in the way people behave in that community when seeking then for the right information. In so doing, making sure that the whole behavioral management then process in its own then intrinsically then kind of counter. So already at the inset, the rumor, right? If anyone would like to add something, I think on that point, and I don't know if
I was muted. Go, Cosmos.
If I may have to add something to it, thanks, Justine. I think there is a lot to learn from the immunization program, as we discussed in that group. This program has been through decades of misinformation and rumors, and has been resilient over the years. I remember growing up back in Africa, in Cameroon, my dad always told me each time nurses came to the school to vaccinate, they all run away and stay away from school for days. So how have they moved from that level back maybe in the 60s, right up to this stage where you can have now that high compliance, mothers willing to vaccinate their kids, and also people walking up to vaccination stations by themselves. So there's a lot to learn from that program, how they have managed over these years rumors and made their programs better. So what are the tools they're using, what systems they have in place, and how can the NTD program in general learn from that?
Yeah, that's a brilliant point. But I would also say that fake news and vaccination, anti-vaxxer movement is also growing across the world, and is building in. And I think it was first sort of across the Western world, but it is now spreading, I would say, across the whole of the globe. So it is an interesting one, and how they might address that as well, and what we can learn from other groups would be key. Yeah, thanks. And there's also somebody in the.
Can I say something on that?
Yes,
as well?
Pam, please do.
I recently heard a very interesting presentation. I forgot, from somebody in the UK who did extra analysis of who had more mistrust, and it was really diving into, they found two groups. One that I should have thought about trying to remember this, but you could dig into the different audiences, and one audience who was having less control in their lives and less resources and having more mistrust, and young parents who were looking for information, and then what kind of information levels they could access. But it was very much also influenced by social media, so maybe it is less relevant, but digging into the differences into the audiences and not seeing your whole entire population as one, and understanding that people can come at these issues of myth and mistrust from different angles. I think that was a key message that came out of that research.
Yeah, no, that's brilliant. And actually, there's something which utterly unrelated to core NTDs, but something we had a seminar given at our institute just yesterday that was really interesting, and it was about the title was sort of treating people in poverty as rational players, and saying that any decisions they make, whether it's sort of if they get fake news and they pass it on, any decision they make, they are as rational as anybody else, but it's what they've been exposed to and what they're currently being exposed to that has made them undertake that, you know, whether it's passing on fake news. I mean, this person was talking about whether it was teen pregnancies or obesity, and I heard about it and went because I thought, well, you know, it's quite interesting for people not using sanitation, because obviously they make that decision because they live in these areas. And but I can actually put the link in here because I would highly recommend it as a talk as well. So off topic, but I think very linked with really working with the community to hear their views and giving them the respect that they deserve for making rational decisions about spreading on information that they receive and what they've heard and what they think they believe and things. So
I have another question as well, if there's enough time. Sorry.
Yeah, we're going to wrap up in just a minute.
Yeah. So a question I had was also linked to you know, the heterogeneity of schistosomiasis prevalence, for example, and the fact that it's a very focal disease, or sometimes also when you're doing, for those doing research projects and you're focusing your particular research project on, in a certain area, in a certain community, well, we know that people move around and that they move from place to place, and sometimes you can have problems arising just from the fact that someone might go into a community from a place that hasn't received any schistosomiasis treatment because maybe they don't have schisto in their area, or maybe it isn't part of a program, or maybe it's not part of a research project, and they move to an area where people are being treated for schistosomiasis, and they start asking questions of like, well, why didn't we receive treatment? Why are you receiving treatment? And how do we deal with that kind of situation? Because that can then lead to certain problems. So remember in a particular project where there was community-wide treatment being tested out and school-based only treatment being tested out in a village not too far away, and the fishing community, particularly the adults who were doing fishing and were very heavily exposed to schisto, but just happened to fall in the school-based treatment cohort, were wondering why they weren't being given treatment for schistosomiasis, whereas in another community just further down, both children and adults were being treated for schistosomiasis, and it led to a bit of sort of resentment, if you want. So I just wonder, how do we tackle that issue as well, because that can lead to misinformation and problems.
Yeah, absolutely. The continuation of information. It shouldn't be a one-off information dissemination. It should acknowledge that situations change and the people in those communities change as well. Thank you, Nick. So do you want to move on to I think in the interest of time, we should just move on to the next slide. And first of all, unless anyone has any burning comments to make. But just to say that this is part of another core NTD session in the main core NTDs that will be taking place in November the 12th. So if you do have any more thoughts, and please do think about how best we can monitor this, how we can create the best guidelines, and there will be lots of kind of further discussions on this, and this will be, yeah, this is in the COVID-19 and NTD session, but really talking about, you know, fake news spreads regardless of what it's about. And so I think there's a lot of parallels to be drawn moving forwards. And from my part, I would just like to say thank you very much as well for all of the great discussions, and I'll hand over to Justin to do a quick roundup.
Okay, thank you very much, Anouk, for the excellent moderation, actually, and all the participants for a very dynamic group. That is the term that comes into mind here, a very dynamic group. So we will then close the sessions, and just to quickly recap, we have navigated through a problem that we believe, as far as the post-COVID and NTD program are about to be launched, a problem that might be arising. So that is of misinformation. Nobody here is immune or has not heard about the infodemic that is surrounding one of the greatest pandemic of our time. So it's important now to put them together in the place or means of mitigations or means of the guidelines then to proceed safely with our NTD programs and then consolidate the gains that we have had by making sure that misinformation is rightfully then identified when it should be within the communities, that the problems that could arise from this misinformation or lack of information are rightfully then mitigated. And finally, once then this is completed, making sure that the populations where all those actions that we have suggested throughout the sessions apply eventually works, that this is sustained, and the community on its own, en route to what we hope then to have in NTD programs, the self-reliance of the community. So en route then to that, then to make sure that the information persists within the community, even in the absence then of the control program, the officer research team. And on that, I would like to thank you again very much for your contribution then to this pre-meeting on the fake news and loss of trust in NTD health program and services, and look out then for the COVID NTD session, as Anouk mentioned, where this will be summarized and provided as operational research question then to inform then the overall session and next steps then as we move forward towards then the elimination of NTD. Thank you all.